Hello and welcome everyone. Today we'll be looking at the role of lung ultrasound in the management and diagnosis of ARDS. Lung ultrasound is critical for diagnosing and managing acute respiratory distress syndrome, offering a non-invasive bedside method that is accessible in diverse resource settings. Now, lung ultrasound patterns in ARDS typically show bilateral B lines and consolidations, which help differentiate ARDS from cardiogenic pulmonary edema by identifying pleural abnormalities or areas of normal lung tissue such as paired regions. Now, the technique and proficiency. Lung ultrasound in ARDS requires a proficiency in specific techniques and terminologies, such as identifying the A lines, B lines, consolidation, pleural line, morphology, and the pleural effusion. Due to the heterogeneous nature of the lung injury in ARDS, lung ultrasound examination should include scanning the posterior thorax as well, especially challenging in supine patients and often requiring a team effort. Now, the equipment and scanning approach. A phased array or a curvilinear probe is used for identifying the A line, B line, and the consolidations. A high frequency linear probe is necessary for detailed evaluation of the pleural line morphology. Scanning planes include the longitudinal axis, visualizing ribs and pleural lines as the bat sign, and an off-axis transverse approach, enhancing the B lines detection by providing a longer pleural line view. Scoring and evaluation. Several lung ultrasound scoring methods covering 4 to 12 lung regions are documented, with the 12 region approach being very common. However, the extent of lung ultrasound examination can vary based on specific clinical indication and the needs. Now, the role of lung ultrasound in the diagnosis. Kigali modification of ARDS initially proposed some modifications to the Berlin's definition. Lung ultrasound criteria were tailored for setting to be used in limited resources, allowing for the use of bilateral B lines or consolidation and lung ultrasound to meet the ARDS imaging criteria. Now, comparisons with the CT scan. Although the lung ultrasound is highly sensitive, they demonstrate low to moderate specificity, especially when compared to CT scan, which is the gold standard in high resource settings. Now, the global definition of ARDS later included the lung ultrasound criteria for Kigali modification, endorsing its broader applicability. The lung ultrasound score for ARDS, a more complex and accurate method, combines data-driven lung ultrasound scores from both of the lungs with identification of abnormal pleural lines in the anterolateral regions. This method is externally validated and shows higher diagnostic accuracy for ARDS. The assessment of the pleural abnormalities. Identifying pleural abnormalities is crucial for differentiating ARDS from cardiogenic edema, although this can be challenging for inexperienced operators. Now, integration with cardiac ultrasound. For unclear cause cases, combining the lung ultrasound with focused cardiac ultrasound can enhance the diagnostic accuracy, particularly in differentiating ARDS from conditions like cardiogenic pulmonary edema. Finally, how lung ultrasound will help us in the management of the patient. Lung ultrasound score for ARDS enables clinicians to assess the severity of the lung disease upon the admission to the hospital. Monitoring this lung aeration daily is crucial for managing ARDS patients, including those who are on ECMO support. A decrease in the score indicates lung recovery and correlates with better patient outcomes, while an unexpected increase can signal ARDS progression or a supervening infection. The presence of a linear arborescent dynamic air bronchogram within a consolidation in the lung ultrasound is highly specific for diagnosing ventilator associated pneumonia, aiding early treatment and improving the outcomes. Changes in the lung ultrasound score after a week of antibiotic therapy correlate well with quantitative CT, helping assess the effectiveness of the treatment. Now, lung ultrasound score can help identify ARDS subphenotypes, that is non-focal and focal. Lung ultrasound score can help identify ARDS subphenotypes, helping in identifying focal and non-focal causes and helping in targeted treatment approach like recruitment maneuvers for non-focal, prone positioning for focal subphenotypes. Now, the lung ultrasound score assists in evaluating the effectiveness of mechanical ventilator setting, including the recruitment maneuvers as well as the PEEP titration, particularly noting the re-aeration pattern in different air lung regions. Lung ultrasound can identify complications like pneumothorax by showing the lung sliding, lung pulse, and distinguishing lung point, which is specific for pneumothorax. Variations in the lung ultrasound score during a spontaneous breathing trial can predict the success and failure of the extubation, and increase in the score during the SBT suggests potential extubation failure due to various mechanisms such as heart failure or inadequate respiratory muscle function. In ARDS patients with hemodynamic instability, an increase in the lung ultrasound score is an early indicator of increased extravascular lung water, guiding lung resuscitation strategies. So to summarize, it has got four major roles. First is in the diagnosis, second is in the monitoring, third is subphenotyping, and finally looking at the complications. So we'll first see what are the findings, the basic lung findings and the aeration scores, which will be done from the scanning the various areas. The scoring is, if it is A line, it's 0. If it is B line, less than 50% of the pleura, it's scored 1. More than 50% is scored 2. And if you find a frank consolidation, is scored 3. Other abnormal findings which are specific with ARDS are abnormal pleura and subpleural consolidation. So you can use these findings in the diagnosis, especially if it is present bilaterally. You can do subphenotyping if you can find these features focally or non-focally. Finally, monitoring. If it is focal, then you go for uh, prone positioning. If it is non-focal, then you go for recruitment maneuvers. You can measure the aeration score every day and see whether the patient is improving. You can check for these scores during SPT trials. So it helps in weaning as well as in fluid resuscitation. And finally, it also helps in identifying the complications like pneumothorax, ventilator associated pneumonia.